All right, doctors, good evening. My name is Dr. Kronk. I'm going to give it another minute. I see we're about a minute early. And then I'm going to get started tonight. And I'm going to show you some documentation.
Sounds like really no. Which actually reminds me, I have some readers to the book charge. So.
Good. We'll get everybody muted up. And we'll get started in just a second. I'm pretty prompt. You don't want to miss these because what I'm going to show you tonight is actually going to, it's kind of like missing the beginning of a movie. If you miss the beginning of the movie, you're going to miss a big part of the movie. Okay, so I'm going to share my screen. You will be able to see my screen. And what I'm going to do is I will definitely, I'm going to do a presentation for you tonight, and then I'll open it up to question and answers. Hopefully, I'll either stimulate some questions or I'll bring some questions. You can pepper me with questions on whatever you want to. What I'm going to show you is how to document so that attorneys will refer more to you. One of the things you got to look at is if you want somebody to help you, you want somebody to be in a relationship with you, what's the benefit of the relationship? Okay, so the benefit to the relationship for you, for attorneys, is you want to make their life easier, which I try to put in these two images. Hey, you want to just sit back and hit the ATM machine, right? If an attorney wants to make your life easier, what's he going to do? He's going to actually fill you with so many patients that you just sit back. You don't have to worry about marketing anymore. You don't have to worry about, the things that you worry about. So we're going to take it from the perspective of, okay, how do you benefit the attorney? Now, for those of you that have never seen me speak before, don't know who I am, I'm just going to give a real short intro. You can look me up. You can Google search my name, Jeffrey A. Kronk, DC, JD. There's about 7 pages of things that I've done, that I've written about, and you can, like I said, search me out. First, foremost, father, husband, grandfather, and I'm a kid. If you get to know me, I'm like a 60-year-old, 12-year-old. So I'm actually more kid than anything, probably. Licensed doctor for 31 years, treating doctor for 17. I was in the rooms 175,000 times. I delivered over 1 million adjustments. I developed 2 spinal ligament injury testing companies. I'm the current CEO of a medical ligament testing company called Spinal Kinetics. I developed I'm chief developer, designer of the system that their radiologists use. I published spinal ligament injury research. I've developed the first online training program for doctors specific to spinal ligament injuries, and also the same thing for attorneys, specific to spinal ligament injuries. I completed a law degree in 2013. I currently am we've developed, but we're in the middle of starting to deploy an AI into imaging services itself, so that an excessive motion test in the future is something that every patient has when they have an injury. Okay, we're going to talk about documentation. I'm a huge guy on, let's find an expert. Let's find somebody who knows what the hell they're talking about, right? Not guessing. So the first thing I'll show you tonight, DXC Technology owns Colossus. So when they own Colossus, they have to develop marketing materials. Now I don't care what you've learned from other experts, and it's all going to be good, I'm sure, from attorneys. Usually what I find is that the blind are leading the blind. So you got somebody who said something to somebody who said something to somebody, or learned it from somebody, or learned it. Let's just go to the source. The source is, hey, at DXC Technology, they have to sell Colossus. Now, Colossus is just a generic term for some sort of an insurance company adjuster software, so they can start to adjudicate claims. It's real easy. Their marketing says your adjusters can quickly interpret medical reports and look up definitions of injuries. Definition of injuries is ICD-10 codes. They can look up definitions of injuries, treatments, those are CPT codes, complications, don't have to explain that one, and permanent impairment using the 5th edition data. Now, they also use the 6th edition data, but using impairment data. Through a series of interactive questions, Colossus guides your adjusters through an objective medical treatment options, Degree of pain and suffering. That means all your, hey, what's hurt? How bad does it hurt? How long does it last? That's your pain and suffering. Degree of permanent impairment, back to the impairment guidelines, to the claimant's body, and the impact on the injury's lifestyle. Those are called duties under duress and loss of enjoyment of life factors. And if you have that, then in order to maintain their lifestyle, you also have the eligibility of future care. So at the conclusion, you got to have this information. At the conclusion, the Colossus consultation, the system, gives a summary of the claim provided, including a recommended settlement range. Just that easy. They just told us, look, no shortcuts, got to have all the injuries located, determined, diagnosed, and coded. Spinal ligament injuries and or fractures, if you're talking about spinal injuries, have to be imaged. Impairment rate, because that's how you would establish them. Impairments rating established, duties under duress or loss of enjoyment of life documented. And if you have a permanent injury with duties under duress or loss of enjoyment of life, you also would establish future care. For those of you that want to come and say, hey, how does this all work? If that's all you want to know, you could leave now. If you understand what I just said, everything else I'm going to say just is going over the points that I just said, right? So I'm going to take a example. This is a doctor who had practiced for a long time, but was always worried about injury work because he was worried about the documentation, hey, the insurers have all these things that they could do. So I'll have him explain to you or just talk to you a little bit about injury documentation.
Hey guys, my name is Dr. Matt Herba, calling from Boston, Massachusetts. I want to actually give a shout out to Dr. Kronk and Smart Injury Doctors Program. If you're looking for a program that makes documentation simple for you, for the insurance companies, and also the attorneys that you're working with, I've never seen anything like this. It's been amazing. So we've been using the program for about 90 days, and I've met with 3 of the largest accident injury or auto injury PIP firms here in Boston in the last 90 days. And we're able to show them how we can easily document injuries, how we don't miss injuries, and how we can really become an expert. I had a large practice in Central Florida for 17 years. We didn't do a lot of personal injury work because I was always unsure about how to do the documentation properly and didn't really know what the attorneys wanted. This program makes that so clear and so easy. The documentation is easy. And not only that, but listen, if you're a doctor out there that wants to level up their care, this is an awesome program because you won't miss the injuries that other doctors would miss. And I'm sure I missed for 17 years. And you can document them properly and you can present them to attorneys and give them what they need. So not only will you help people that are in auto accidents, but you can really help your other patients. So I'm so happy about this. This has been an amazing program. It's been one of the best programs that I've been introduced to probably in the last 10 years. So Dr. Kronk, thank you so much. And everybody in the group has been so awesome and helpful. This is Dr. Matt Herba from Boston, Massachusetts.
Okay.
Hey guys.
So we're going to start with number one. Number one, the basics to all injury documentation. Now, I'm going to back up. You've heard me speak. One of the biggest problems that I say is in the market is there is no formalized training for injury work in any chiropractic school in the country. No formalized education program on injuries. No, hey, let's take 2 semesters of spinal injuries. Number one cause of chronic pain and disability in the world today. Largest driver, 292,000 medical visits today just for injuries. That's not chiropractic. That's not physical therapy. 115,000 ER room visits today for injuries. 60% of that spine related. No formalized education in chiropractic, no formalized education in physical therapy. Doctor of PT doesn't have any formalized education. No formalized education in medical school on spinal injuries. Everybody learns it on the fly. So real simple. Number one, first obvious thing you got to do is you got to document the injuries, right? So a patient comes in, says, look, I was in an auto accident. I got headache, upper neck pain, dizziness. I got level at 8 out of 10 on all of them. Okay, diagnosis is the idea of symptoms working backward to tissues. If I come into a doctor and say, look, I got chest pain, I got chest tightness. When I go up 5 sets of stairs, I feel like I want to pass out, and my ankles have been swelling for 2 weeks. You don't have to be much of a doctor to say, wow, I'm pretty sure your heart might be involved. That's what we have to look at first. That's symptoms to tissues. Symptoms to tissues. All right. Is a headache caused from a disc herniation? No. Upper neck pain? Possibly. Dizziness? No. Right? So we have to start to work. Now, let's say I went and did a heart workup with that same symptom complex, and my heart tested 100% perfect. Okay, now we got to start to look elsewhere. But we don't miss the most common thing that causes the problem. Right? So you look at this and say, all right, these are my symptoms. I got to work my symptoms backwards. And injury means a derangement to a body part. Impairment means derangement of a body part. So if I look at the derangement, or I look at a spine only has 3 potential main injuries, right? It's only two parts, just bone and connective tissue. The spinal cord is not the spine. It's a different part. I could sever a spinal nerve without ever injuring the spine. So if I'm going to injure the spine, which probably everybody on the call knows, there's only 2 parts to it. There's bone and connective tissue, right? 23 discs, 220 specialized ligaments. The majority of the ligaments are called support ligaments or non-disc ligaments. So I look at it and say, look, I could break it. I could have support ligament damage, which shows up as excessive motion on x-ray testing. Or I could have disc herniation. Or I could have combinations. I could have excessive motion and disc herniation. I could have severe disc herniation, or I could have severe disc herniation with no excessive motion. I could have severe excessive motion with no disc herniation. Right? So I got to be fluid with this stuff. I can't be stuck. I got to be fluid. Now, disc herniation, generally 2 symptoms. Ligament injury causing instability, lots of symptoms. Right? So I look, if I go out and I say, well, gosh, remember, I'm going to make the attorney's job easy because I know my stuff. So that he doesn't really have to know his stuff, or she doesn't have to know his stuff. I know my stuff. Right? Now, knowing my stuff does a number of things. One, it's good for the insurer. Because if you know your stuff, you're going to get better results. And if you get better results, you're going to cut down what the insurers have to spend. It's going to be good for the attorneys because it's going to give them the ability to turn their cases quicker. It's going to be great for the defense attorneys because they don't have to work hard either. It's going to be great for the patient because generally those doctors that understand the injuries get better results. Disc, if I go to Medscape, says 2 symptoms, pain and radicular pain. Did my patient have any radicular pain here? No. They have pain, all right, possible, but no radicular, right? If I look at the other ligament injury symptoms, I got a lot of them. Right? The majority of ligament injury is to the non-disc ligaments. I got to know that. Now, I'm not teaching you that tonight. I'm teaching you documentation. Right? So if I look, I got to go, well, okay, this guy's got upper neck pain. He's got headaches. He's got dizziness. I got to know, did he break his neck? Does he have excessive motion? These are very common with excessive motion and spinal instability. Or does he have disc herniation? Well, only one of the symptoms potentially is a symptom of disc herniation. So the majority of my symptoms here, and even though I'm not listing a lot of them, we could have listed a lot more. I'm just doing it for tonight for purposes of teaching. Now, could I also have a traumatic brain injury? Yeah, I could. But even if I have a traumatic brain injury, right, I got to rule in or rule out this disc or this ligament damage first, because I got to stay simple, just like the heart example. I got to stay simple. The most common is ligament injury causing instability. Now, there are some research that says, hey, while most individuals recover from a single concussion, that means they recover whether they're treated or not. Up to 1/3 of those will continue to suffer from residual effects such as headaches, neck pain, dizziness, and memory problems, 1 year after the injury. Symptoms characterize a disorder known as post-concussive syndrome and are much like those of whiplash-associated disorder. Both disorders are likely due to cervical instability. That's the most common thing. If I do a workup and the patient's still suffering and I look at a chiropractor's workup, no excessive motion testing. Have no clue how much instability you're missing. Same with a medical doctor, same with a DO, same with a doctor of PT, right? So the first and foremost thing you got to do is understand what you're diagnosing. What injuries are you looking for and find them? So the first thing you're going to do is you're going to do great stress x-rays, because that's how you determine the support ligament damage. You're going to use an unbiased independent third party when possible, because the results are so significant that you don't want the bias of somebody being able to say, well, the provider's biased. And in medical systems, everybody refers. And the perception of the medical community, whether deserved or not, it's very high. It's very high, very professional. So when you look and you send out, you get a test, right? It shows you excessive motion. Now, here's an example of a test. Now, again, this is not to teach you how to read a test. I'm going to assume you should. If you don't know how to read an MRI, you probably shouldn't be in spinal injury work. If you don't know how to read an excessive motion test, in my world, that's the same. Now, excessive motion tests are the same, pretty much the same, just like MRI reports are the same. I don't care if you go to ABC MRI, Med MRI, Downtown MRI, San Diego MRI, if the patient comes out with an MRI of the cervical spine, reading the report, no matter who does it, is pretty similar. Excessive motion testing is the same. This excessive motion test shows me that I have severe ligament damage in the craniocervical junction. That's going to handle my headaches and my dizziness. That's the most common cause of it. Now, it also tells me, in this case, that I have grade 3 sprain findings and grade 2 sprain findings. That's based on the amount of excessive motion there is. More excessive motion, higher grade of sprain. It also, in this case, tells me, wow, the neck pain could be coming from the fact that I have a mid-cervical injury that's quite severe. As a matter of fact, it would qualify for pre-authorization of a spinal fusion surgery. So if I just go to the spinal fusion guidelines, it says, hey, wait, what do we got here? I got a C5 that has an angular finding of 20.17 degrees. Well, guess what? If I go to one of the largest insurance company, assistant company that assists with insurers with guidelines and how to determine if their pre-authorizations are valid or not, called EviCore, I look at their fusion guidelines. It says, hey, if I got 11 degrees of relevant sagittal plane triangulation found on X-ray, not found on MRI. There's no MRI findings in here at all. Yeah, go ahead. You guys confuse that. Now, are you going to have every patient have a fusion just because they have that? No, your job is to actually stabilize it. And for the most part, you do a good job of stabilizing it. Many of you don't even know you're stabilizing these things. You do a much better job when you know what's there, in my experience. So I also can look and say, well, gosh, this also covers me with, I have an impairment. So I have a grade 3 sprain findings, grade 2 sprain findings. I have a potential surgical. I have an impairment that's listed in the impairment guides. I have return to play parameters and athletic return to play parameter guidelines that should be considered. So if I look to return to play parameter guidelines and I say, well, gosh, this person does jujitsu and kickboxing. They were just in an auto injury. They have a severe ligament injury. I should restrict them from that activity. Athletic guidelines kick in. Now, the more I use guidelines and the more what am I using? I'm using consensus. Now I'm making it harder and harder for anybody to argue with me. Because I don't want anybody to argue with me because I'm too damn busy with people. Like, I know I've got to interface with this medical legal, and the bigger I get, the more of it I got to interface with. So the more of it I got to interface with, the more I want to be consistent with guidelines and my understanding of the injuries and my understanding of what everybody needs, including the insurer. So I'm not getting tagged up, like, bogged up in the medical legal process. So I just want to help people, and I want to develop clinics that really help people. right? So I also look and say, geez, this automatically qualifies me for grade 3 or grade 4 in the Croft treatment guidelines. So in the Croft treatment guidelines, that allows me up to 76, if grade 3 allows me up to 76 visits in a 56-week treatment duration, the majority of which I'm never going to use. I'm going to stabilize way beyond that, way before that. But if I'm saying what I'm using, then that's what I have to be judged against. That's what I have to be judged against. So this makes it really easy. It also tells me if I've got excessive motion, current research tells me that I have a high level of sensitivity and specificity for disc herniation. So now I don't have to be in the revolving door of, oh, you're a chiropractor, you get it from the attorney, you send it out for MRI. Everybody goes for an MRI, 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 MRI. No rhyme or reason. Slaves to the system. You know it and you don't feel good about it. I know because I talk to doctors a lot. All right. It's not a bad thing, but it's a better thing to actually have great clinical rationale for why you're doing it. And it's so easy. If I've got a disc herniation, the first thing anybody should be asking is, what are the support ligaments doing around the disc herniation? Above, same level, or below? Because if you've got serious instability with a disc herniation at the level, above the level, or below the level, you have one of the worst axial spine ligament injuries that's not catastrophic that you can have. Is that going to take longer to treat? Yes. It's going to take longer to stabilize. Generally, yes. Does it kick in greater treatment guidelines? Yes. Might you need other allied professionals to assist you in the treatment of this person? Yes. But are you setting up everybody up for the basis of the documentation? Pain management people love me. I just set up their whole case. So when they're taking a 50% reduction at the end because the insurance is all worn out, they're settling it for higher. So they like me. The insurer likes me because I get things done quickly. Not everything's not a cookie cutter. The attorneys like me because my documentation is really consistent and I'm using guidelines. So I don't have to argue. So I'm going to give you an example. And this is just an example of research. And this is called ligament injury connection to osteoarthritis. And by the way, excessive motion causes accelerated degeneration. That's what causes accelerated degeneration. So it says the ligament component. This, by the way, is, let's see. This, by the way, let me actually do something once real quick. Let's just make that a little bit smaller and now go back to it. Slideshow from current slide. Okay, so this is from 2011. This is from the people who are doing regenerative medicine. So this is Journal of Prolotherapy. It says a ligament component. Ligament component means this component of ligaments around the spine and around the disc, not the disc. So it's the 9 ligaments around the disc. The ligament component of spinal stability is related to the support, health, and proper function of these tissues, and often overlooked as a major, if not the major, source of back pain and ultimate degeneration. The case can be made that excess or even complete dependence on what yawn, the MRI, has focused too much attention on the intervertebral disc and the vertebrae themselves to the exclusion of the ligaments in the facet joint capsules. Here's an example of it. 15-year-old girl, been to a chiropractor for 2 years, did an MRI, I think 8 weeks into it. Everyone gets an MRI in Minnesota. It's completely clean, clear. Been all over the place, still has really bad symptoms. Attorney hears a lecture by me. Very similar to the one you might have heard tonight. Pretty similar, actually. Just going through the injuries, the 3 basic injuries. Says, wow, I bet she's got an excessive motion injury. Sends out for DMX, sends it to the company that I'm the CEO of, it's called Spinal Kinetics. She has 2 severe, both angular and translation findings. Now, he doesn't explain this perfectly, but listen to what he has to say.
Doctor, let me explain what opened my eyes to the situation was after listening to you. I had Gina's case.
All right,
Gina
good.
was was a 15-year-old that was in a car accident, and her chiropractor did an MRI 2 to 3 months post-accident that showed up perfectly normal. 2 years later, Gina is still having significant cervical pain. And I used that as my first test case. We had x-rays done. In that particular case, they were done by motion x-rays, but digital motion x-rays. And your spinal kinetics did the assessment, the computerized assessment and evaluation, and turned out that she had significant and rateable objective findings of significant motion segment integrity, both in her case, both angular and translational.
Yeah.
And I decided to go back and have her have an MRI done a little more than 2 years later. And all of a sudden, this 15-year-old spine that had been imaged by MRI right after the accident as totally normal shows the degeneration of a 45 to 50-year-old lady.
Exactly what the research just showed. 100% exact. No disc herniation. Severe ligament damage. Exactly what I said. So first, you got to know the injuries. You got to know the 3 injuries. You got to be able to work those 3 injuries up. And you got to work them up. You got to work them up every single time. That's number one. So there's five basic things. That's number one. Number two, you got to know if the injuries are permanent. The only way is using the permanent impairment guidelines. Permanent impairment guidelines are super, super simple. You got 3 injuries. Fractures, there's a fracture column straight across the bottom. If I got a 50% or greater compression fracture, I got a 25% whole person impairment. If I got greater than 3.5 millimeters of translation or greater than 11 degrees of angular difference due to the support ligament injury, category 4. So, Dr. Kronk, are you saying that this ligament injury is the same as a 55% compression fracture? No, sir, I am not. The AMA is. But I agree with it. Okay. This makes this stuff so easy, right? Now, let's say you have less than, let's say you got 3.2 millimeters. Does it fall in this column? No. But does that 3.2 millimeters cause asymmetrical loss of range of motion? Yes, almost always. Good. Then it falls into this category. Got a disc herniation with radicular complaint, falls here. Radicular complaint goes away with your care, falls here. That's the impairment guidelines. Fractures, excessive motion, disc herniation, disc herniation. This is the simplest stuff I've ever learned. And it's just that simple. If you try to make it more complicated, you're just complicating it. And if you have never seen anybody put it that simple, that's what you need to hook up with. Find people that can make it simple. Let's deal. I do a lot of webinars, seminars, all kinds of stuff. Here's a personal injury attorney out of San Diego. He wrote a book. It's a very, very good book, of which I think it's, I don't remember the name of the book is. If you email me, I'll give you some contact information. I'll get you the book. His name is Mark Blaine. He has a book out on Amazon. It's probably the best book I've ever read on documentation. It's a great book. He's an attorney. Here's what he said about impairment rating.
Okay, so this doctor's asking you, what is the case value increased with the impairment? What is case value increased with a permanent impairment? Which you and I are both going to say that it depends on a lot of different factors, but go ahead.
Oh yeah, it really does. But just off the bat, 15 to 30,000 could be the difference on a soft tissue, what they would call soft tissue. What would be called a soft tissue case in the beginning, meaning just muscle, nothing touching on ligament, no, bone, or nerve. Yeah, 15 to 30,000. So one case, not what we have.
Say that again, Mark. Say that again. So
yeah,
what?
It could be $15,000 to $30,000 difference on an average case, doing what we're talking about for the patient.
Yeah.
One case, it was a soft tissue case that came in, but we had it appropriately documented with the impairment. And I think this one had both the cervical and lumbar at full max, 45%. That one's that one's over 60,000. Now that would have been, if you didn't do all this, then that would have been a $15,000 case.
Okay, so if you didn't do all this, that'd be a $15,000 case. Depending on the factors, it gets higher and higher. But remember, the factors of a personal injury case go up if the patient is not improving or hasn't improved. So if you've done a great job with the patient, which is what your job is as a doctor, your job as doctors is to reduce claim value, not increase it. Patient comes into your office and they're in a wheelchair from a back injury. They've been to the medical doctor for 6 months. They were in an auto accident. They can't get out of the damn wheelchair. And then in your office for 6 months and now they can run a 6K run. What did you do to the claim value? You reduced it. The attorney should have settled the case while they were still in the wheelchair and can walk. Okay, that's your job as doctors. But you don't have to worry about that because there's permanency to injuries, and at the level that the majority of providers play at, you don't have to worry about the fact that that's what you're doing. You may not go out and communicate it like that to the attorney, but that is what your job is. That's what you're doing. So we got 1, the injuries, 2, permanency, 3, the effect it has on the person's lifestyle. Those are called duties of duress or loss of enjoyment of life factors. And they're easy. They're just forms that you're just filling out and say, hey, do you have any problems doing things in your life? If so, what is it and how long? Hey, vacuuming. If I vacuum for more than 30 minutes, I have a problem with it. Well, what do you do? Why would you vacuum for 30 minutes? Because I have a 16,000 square foot house, whatever. Or because that's what I do. I help a friend out. She has a house cleaning service. Okay, so you just list the effect that these things have on the person. Duties under duress and loss of enjoyment of life are just forms. Anybody can Google search and say, hey, what's a duty under duress or loss of enjoyment of life form? You Google it, download it, once in the beginning, once at the end of care. Pretty simple stuff. So that's 3 and 4. 5 is if you have a permanent injury. Now remember, we also have outcome assessment procedures to determine if our care is working. I'm not going to get into all of that. I'm just going to get into the basics tonight of the 5 things that you definitely always have to have. So if you have a permanent injury and you have duties under duress and the injury is still causing the person problems, then you could have future care needs. Now there's 2 terms. Take a picture of this one if you want to. There's 2 terms, and these terms came from position statement on the American College of Chiropractic Consultants, 2006. I think they're done as well as I've ever seen the terms done. And there's a term, maintenance care and supportive care. So let's talk supportive care first. It's long-term treatment or care that is therapeutically necessary. This is treatment for patients who have reached maximum therapeutic benefit, but who fail to sustain benefit and progressively deteriorate when there are periodic trials of treatment withdrawal. Supportive care follows appropriate application of active care that patient does for themselves, passive care that they receive at your clinic, care, including rehabilitation or lifestyle modification. Supportive care is appropriate when alternative care options, including home-based self-care and referral, have been considered and or attempted. Supportive care may be inappropriate when it interferes with other appropriate primary care or when risk of supportive care outweighs the benefit, i.e. treatment dependency. So if a patient, remember, most of your patients, you're judging how they do while they're under care. Research says that while they're under care, the different techniques compare pretty closely in chiropractic, but what doesn't is if you haven't improved alignment, research says that patient's holding their care or holding their results is going to deteriorate over time, i.e. they're going to go into chronicity, which 55% or more of the patients do with spinal injuries. That's why supportive care or maintenance care is important in the life of the person. You all know that. You've been under maintenance care. Maintenance, the only difference in maintenance care is just elective. You're not really treating anything. You're basically treating the patient so that they don't get the things that they don't want to have. That's the difference, right? So 5 things: injuries, all coded, severity and location, documented, imaged. The injuries need to be imaged, especially in the spine. No questions asked. Permanency, you're using impairment guides. If attorneys don't like impairment guides, they like surgery. The same impairment findings are in the surgical guidelines. So explaining things to attorneys is not hard. But if you're just going to go out and explain to them impairment, then impairment ratings, or here's an excessive motion test, good luck. I never promote that you do that because it doesn't work. So I want to give you another example of, okay, here's a doctor, and I'll give you a couple more. Here's a doctor who's done those things now is in court.
Hey, Dr. Cron.
Hey, Dr. Smith, I got you on record, if that's all right with you. Is that all right with you?
Sure.
Okay. You called earlier. What was the call about?
My first case settled, and it settled for $370,000.
Congratulations. What?
Okay,
Now, that was the one that you were in court just Tuesday, right?
that's correct.
Okay, and that was your first one where you did testimony on ligament damage.
That's correct.
And you had if
I
I
had a
remember,
good time.
and you had a good time?
Court, yeah. I wasn't scared. I wasn't flustered. I didn't have any problems in court. The attorney for my patient kept me on the stand for 3.5 hours. I didn't know it was that late. I know that I was thirsty. I
Yeah.
didn't have any water. And
Okay, so the time went by pretty quick. In other words, you would obviously.
yeah, well, I wasn't just sitting there. I had the pictures of the model, you know, the one that I think you've shown it before that's got all the ligaments on it, the 10 ligaments you always talk about.
Absolutely.
I explained that. I also had a model, and I showed how the spine sheared in the accident.
Yeah.
And then I used the
So you actually showed the mechanism of injury and the lesion that's left behind.
that's correct.
Good. So what did I just say? Mechanism of injury is a force delivery system. Lesion that's left behind is the derangement or the actual injury that's left behind. It's the easiest thing in the world to explain. Just got this morning. Appropriate for this. This is a chiro. Patient was in an accident in 2015. Insurance was offering them zero. He was in a. I just want to let you know how a recent case came out that I testified a few weeks ago. The defense offered zero. The patient was hit from the side on the highway, immediate headache, felt like a bomb went off in his head and never went away. Severe chronic neck and back pain since 2015. Defense hired a biomechanist, that's an accident reconstructionist, to say that he couldn't have been hurt at such low forces. The defense MD that did the teleconference, IME, not AMA standards, so they had an IME. Defense neuropsych stated that he did not have concussion complaints, false documented from the beginning, and also stated they had a personality of over-exaggerating. They had a private eye demonstrating that he could lift a four-wheeler. He was buff, but would be in bed for 3 days after lifting the stuff. Side impact in 2015. There was an instability demonstrated on initial, confirmed with DMX, and more recent lumbar flexion extension x-rays, because the DMX is not capable of penetrating the lumbar spine. So I was a second opinion IME, initial rebuttal expert, lead testifying expert. So he's the lead. He's the lead in this. They're going to court, right? So he gets this case after they've done treatment, and now he starts. I discussed the side impact mechanism, how seatbelts did protect. There was a higher documented serious injury in the side impact, and thickest ligaments only protect in the axis acceleration. So he's explaining these things. He's explaining these 5 things that I talk about. He's explaining it here. He has grade 3 sprain findings in the cervical spine, grade 3 sprain findings in the lumbar spine. Doesn't have a disc. Just got word yesterday, it's settled for $6.1 million. Now, that's what's possible when you know your stuff. Now, I'm going to play a fun little video. This is just a little intro video, and then we'll get into question and answer. Good. So that's what we create. We create what I call smart injury doctors. And those are some of the best doctors in the country for these injuries, bar none. They learn the injuries. They learn how to work up the injuries. They learn how to document the injuries. They make life easier for everybody. And in that case, they generally, business-wise, grow. Now, before I open it up to question and answer, I just want to make sure that you're aware of other resources that we have that are free. I have a Smart Injury Doctors podcast. If you go to Apple, you go to Google, you go to Spotify, go to major podcasters, put in Smart Injury Doctors, you're going to see about 105, 106, 110 episodes. Short, sweet, to the point. You start listening to them in the car, you start listening to them, period. It will help you in the injury space. We have a Smart Injury Doctors Practice Building Sex Secrets private group on Facebook. You Google search it and ask to join us. You'll get all kinds of interesting education just like you got tonight. If you got questions or answers for us or for me, go to 800-940-6513. If you say, well, look, I want to know more, that should click through. I want to know more about your program, then we wouldn't be able to get there. You just go to smartinjurydoctors.com. Hit learn more, give us your email, give us your name. It'll take you to a site, and it'll take you to a place where you can see all kinds of video testimonials of doctors, but you can then go through that, and you'll see a program that says, hey, this is all that this program has to do. So at this point, what I'm going to do is you all have the ability now. We're going to come back together. You can ask me any question you want to. All you have to do is unmute yourself. If you look in your far right corner, you just unmute yourself, or you raise your hand. If you go to the reactions, you'll see there's a hand where I can just raise my hand. If you raise your hand, I'll just pick on you. I'll say, okay, Peter, what's your question? Joe, what's your question? And you can just unmute yourself and you can ask questions away. So I will stay here as long as you have any questions at all. You don't have any questions?
Jeff?
Yep.
Hey, this is Barry Shulak.
Hey, Barry.
Hey, what was the fourth one? I got distracted and I didn't, the slide went by pretty quickly and I didn't write it down.
Duties under duress, loss of enjoyment and life factors.
Loss of enjoyment and life factors? Okay.
Yeah. Yep.
Okay.
So, and those are, if you just Google search them, there's forms for it. It's super, super simple.
I do have another question regarding documentation, and I'm kind of wondering, it's like, how do you strike and maybe I think there's maybe like an art to this, but how do you like kind of strike a balance between being detailed enough so that you're really giving good information and like not overdoing it and making your notes, so lengthy that it just takes like you forever to document what you're doing?
You want to have super lengthy notes. You want to have a book. You want to have, wow, I got ChiroTouch to spit out 4 inches of stuff. You better have a summary of something, some sort of a summary of what all that means, because that's all anybody wants to read.
Mm-hmm.
So hey, what are the injuries? Here's the codes. Here's the codes. Here's the injuries. Here's what I diagnosed. Here's the imaging that supports it. Here's what the impairment level is. Here's the page that supports that. Here's the forms. This is what the person said. This is their duties under duress, loss of enjoyment of life, problems. And this is how we've assessed the fact that they have some need for future care. Maybe it's a case where you have a amount of excessive motion. You've stabilized it, but you're sending it over to a surgeon, and the orthopedic surgeon says, yeah, in the future, they may need, for that injury, they may need a spinal fusion surgery. They're not needing it now. They're getting good stabilization, but they may need it in the future. That's a future care recommendation.
Okay.
So it's pretty much that where it gets unsimple is you have to start. You just have to start doing it. So
I have been, but I find that as I've learned more in I'm like taking more responsibility for my patients and, being more aware of just how injured these people are. I'm trying to work out the best way to explain these things like as succinctly as possible so that they're documented,
Yeah, no. So education programs like this, education programs like Smart Injury Doctors, my thing is if you can't simply look at things very quickly and understand it, then you probably have some work to do.
Okay.
Right? Because if I show, let me go here. In doctors, I do a lot of attorney education programs, and I teach a lot of doctors to do. I could give you testimonial after testimonial. Nobody came up with this. This is mine. Now, it's not mine. This is just what the injuries are. Just nobody makes it this simple. There's only 3. These are the injuries to the spine. These are the derangement patterns to the spine. Disc herniation, support ligament damage, or fracture, or combinations thereof. It's just bone and ligament. So there's nothing else to derange but the bone or the ligaments. And these are what the derangements look like. And the consensus on the derangements is off the charts. So I don't have to argue. Now, if you don't know what the consensus is, you're going to spend a lot of time arguing. But that's just presentation. That's just because you don't understand the presentation and you don't understand the resources that would assist you. So if I look down here, this patient, wow, okay, we work up this patient, right? I send him out. I do great flexion extension study. I send him out. He's got upper cervical instability. C1 and C2 are off the charts, falling off. Right at C2 and C3, he has a ratable level of ligament damage, which means he's got excessive motion. Let's say it's 4.2 millimeters. Now, is that going to cause the upper neck pain? Yes. Is that going to cause dizziness? Yes. Is that going to cause headache? Yes. Got all my symptoms handled. All I got to do is go to Medscape or there's even other resources, but Medscape's probably the best one. It's the biggest medical site in the world. And it says it. So I look and I say, good, I got to do an excessive motion test. I do that right away. Again, that tells me right away. As soon as I do an excessive motion test, it tells me, well, gosh, do I have craniocervical junction ligament damage? Yes. What grade of injury do I have? What grade of sprain do I have? I got 2s and 3s. Okay. Do I have anything that's a surgical issue? Yeah, this falls into the surgical guidelines. Now, it just happens to be the same information that falls into the impairment guidelines, which happens to be the same information that falls into the return to play athletic in contact sports athletic parameters, which also then tells me, geez, I got a grade 3 or a grade 4 Croft treatment guidelines. So when I kick into my chiropractic treatment guidelines, I'm right there. Now, I also can know that I have a high predictability for disc injury. Now, when I get this report, everything that I just showed you, I can assess that in less than 60 seconds. I can also communicate it in my documentation. When I can assess it in 60 seconds, my documentation is not complicated. Now, do I still have to do the books of outcome assessment, SOAP notes? Yes. Yeah, I still have to do all that, right? But you got automated systems today that make that super easy. Do I have to do re-evals? Yes. Do I have to track the symptoms? Yes. 12 symptoms started, 4 left, 8 fell off. Good, I got to track that. I have to track that stuff. Do I have to do my range of motion testing? Yes. Muscle testing? Yes. Whatever it is you do. Pressure algometry testing? Yes. Dynarom, SEMG, Dave Markarian stuff? Yeah, sure. How about my pain questionnaires? Sure. Could I do an ADL questionnaire in there? Sure. Do I have good, clear rationale for what I'm doing? If I make a referral and I'm referring out to pain management, why am I referring out to pain management? Hey, I got excessive motion. The excessive motion is significant. Significant excessive motion is going to cause facet problems. That's the number of reason why you're going to send out for shots and have ablations. So I got all this stuff covered. I'm like covered in the first hour. My first hour, I know a lot of this. If I'm sending out for the test results for excessive motion, I know this within 60 seconds of looking at that test result. Just like I know if I got a disc herniation within 60 seconds if I'm looking at the MRI report. So I know what I have based on being able to look at the stuff. If you're not consistent or you don't understand how to look at this, you're not understanding how to look at the injuries. And even though you're treating them, there's improvement that can be made that seriously improves your documentation and seriously improves outcomes, no matter what outcome you want to improve. And that can also mean referral outcomes.
Dr. Levy,
So does that make sense? So it's just, but you got to get used to it. You just got to do it. You have to do it repetitively over and over again. It's like an adjustment. The first time you did an adjustment, you're sweating, you're nervous, whatever. After you do 100,000 of them, you don't even think about it. So as you start to really get smooth with your injury documentation, you get to the point where you don't even think about it. It's just smooth. Because there's not that many things you have to document. Does that make sense?
Yes.
Okay, so let me stop that. Any other questions, doctors? Again, I'll stay on here for hours. I love these topics, but I won't stay if you don't have questions. So if you got questions, I'm all here for you. If not, and you feel like, wow, I just, this was great, but I don't have a lot of questions on it, I'm okay with it. If you're doing good, if you've had depositions, you've had trials, you've been good with that. And by the way, the majority of what I showed you tonight, when I showed you that, hey, look, this was 6.1 million and this was 350,000 and this is going to court, the majority of what I'm teaching here keeps you from ever going to court. Right? But it's the same information that if you went to court, now you're in a different area. You don't want to spend a lot of time in court all the time because only 1% of the cases ever go to court. So the majority of what I'm showing you is seriously helpful for the 99% of the stuff that never goes to court. Never. So I just wanted to throw that in, even though I use some of the testimonials on court just to show you some results. It's not about going to court. It's about staying out of court unless you have to go. And if you do have to go, then it's about being very effective in a deposition or court as well. Okay, either raise your hand, unmute yourself, and ask away if you've got a question. Don't care what the question is. Don't care if you're a medical doctor, chiropractor, attorney, IME provider, insurance adjuster, don't care. Ask away. Okay, I'm going to give about 10, 15 more seconds of me filling in where there is no question. And if I don't hear another question or see a raised hand, then we'll just call it a night. And hopefully I gave you something of value. We're going to do a lot of these. If you ask for, you can call 800 tomorrow. Share my screen. I'll go back to this. You have questions or you want to know more information or you want to see more information, go to Smart Injury Doctors Practice Building Success Secrets on Facebook and ask to join our group. Highly recommend you're driving in the car, you start listening to these. These will blow you away. They're short, 9 to 12 minutes usually on a particular topic. And I just riff on that topic a little bit. Right to the point, straight, pure stuff. If you have interest in the Smart Injury Doctors program, you just basically go to the Smart Injury Doctors site and hit learn more. Okay. John, Dr. Tate, unmute your, there you go. What's your question? And I appreciate you asking a question. Dr. Tate. You would have to
All
unmute.
right.
There you go.
Oh,
You're
sorry.
good.
Can we get a link to the slideshow presentation that you shared today?
Can you want my slides?
Yeah.
Yeah, that'd be good, wouldn't it? Like the whole deck?
The ones you went over today, at least.
Yeah. Call 800. Generally, I don't give out my slide presentations.
Fair.
Obviously you can record them, you can build them, you can do whatever. I do in our program, obviously all of our slide presentations and everything else comes in our program, but I generally don't give those.
Okay.
Good. Do you have any questions on what you saw tonight? Did you like it?
Oh, yes, I did.
Okay. Any
Very
questions?
succinct and to the point.
Yeah. Okay, good. I like those comments. Thank you. That's the goal. I like those comments. So thank you. And thanks for coming tonight, John.
Yeah, I appreciate you inviting me.
Yeah, you're welcome. The other thing, John, is just so you know, in that Practice Building Success Secrets, if you join that group, you'll see this recording in there. Now, in that recording, you can grab screen capture shots, you can screen capture stuff for your PowerPoints and everything else.
Okay.
Okay? So it
Yes,
makes
sir.
it, you grabbing you know what I'm talking about. You can just screen capture right while you're watching the video, and now it's right in your presentation.
Right. Yeah.
So just call that 800-940-6513 or go to that Facebook site, join it, and we'll let you in, and you'll see you'll see this and other recordings are already out there.
Okay, perfect. That was going to be my next question is, I think I missed part of the beginning. So if there was a replay.
Yeah, no, you'll get it. You'll get it. But you got to go out to that Facebook private group to get it. You know which one I'm talking about?
Yes, I think I might be a part of it already.
Okay, good.
So I'll look at it.
Perfect. Okay, let's go to Dr. Pilley.
Hi, Jeff.
Hey, Dr. Pilley.
Thanks for this presentation. It was very informative. As you all know, I'm considering joining the program. Do you take us, walk us through the sample case presentations and walk us through your whole system and how to prepare the report with documentation, everything that you talked about? Do you walk us through all that?
So once you go through the program, you know what to do on the reports.
Okay.
So we do coaching, and I can coach. If you have an example where you say, hey, look, here's an example, and this is how I'm doing it, then yeah, it's pretty easy. It's not that hard. And for those doctors that are, we have a lot of chiropractors on the call, but Dr. Pilley is a pain management specialist in the Philadelphia area, correct?
Buffalo.
Buffalo. Oh, sorry. Is Buffalo close to Philadelphia?
Somewhat, I guess.
So he's a Bill and not a
right. Oh, proud to be a Bill. Proud to be a Bill.
Yeah, but for you DCs, he, in his understanding of the injuries and the documentation holes, would, as the pain management specialist in my area, be exactly who I would want to work with on my pain when I need help with the patient. I'm not going to need help with all patients, but I'm going to need some help with patients. And when I have an aligned doctor that understands the injuries like I understand the injuries, I can either use that doctor to assist me to go into attorneys and to other medical doctors. That doctor can use me to assist in going to attorneys, or you can go direct.
Mm-hmm.
So it just makes it a lot easier. So if I plunk down in Buffalo, right, and I just started practice, one, I'm going to start to do the things I just showed you, but I'm also going to start to find where are the network of doctors, the pain providers, the orthopedist, the surgeon, the neurologist, the things that I might need. Where are my doctors? And it might take me 2, 3, 4, 5 pain management groups before I find the right one that I want to work with, right? Because look, I'm still a DC, And as far as I'm concerned, DCs are the top treaters in the world on spinal injuries, but it doesn't mean that they're still not a prejudice.
Mhm.
So, obviously I want to find somebody who's not prejudiced because I'm a DC, or I'm prejudiced maybe because I'm as knowledgeable or even more knowledgeable in this area. So,
Right.
you got to learn to work with the doctors. And so, that would make it very, very easy. But yeah, Dr. Pilley, walking you through and working you through like an example is not hard, because it's doctors, people say, oh, I don't like canned documentation. Listen, a dentist never gets attacked for canned documentation. A dentist is only treating so many things,
Mhm.
right? And there's only so many ways that you can say those things. It's the same with spinal injuries. There's 3 injuries. You're working up to 3 injuries.
Mhm.
And so there's repetition to it. And once you start to understand the repetition to it, it's pretty easy. I mean, right now, you don't have any problem working up disc herniations, and you know what to say about it. You know how to report it. The other injuries just as easy to do.
We've had discussions before, and I even had you speak to one of the attorneys I work with, and in Western New York, I guess it's kind of cookie cutter. They look at the MRIs and just look at those findings, but they don't look at the non-discal injuries. But is it pretty easy to make them believers, and based on the documentation that you have, and relating to the disability, I guess, scales that you have, the
Yeah.
impairment ratings?
Yeah. So it's yes. The answer is yes.
Yeah.
Because what they run into again is the disc does not cover the majority of symptoms that the client has.
Correct. Mm-hmm.
So if the client had bad elbow pain,
Mm-hmm.
but they had no elbow findings, doctor looked at their elbow and said, there's nothing here. There's no injury to their elbow. There's no injury anywhere.
Mm-hmm.
I mean, okay, so the majority of symptoms that you see today are not related to a disc herniation.
Mm-hmm. Okay.
But yet that's what the lawyers know. So it's very easy to bridge them over to the other injury. Very easy. You as a medical doctor, it's like, if I was a medical doctor, for me, a medical doctor, being a medical doctor, going in and talking about this would be like if I had a full head of hair and was a high-end GQ guy going into, I don't know, to community. I mean, I go in, I'm a Neanderthal bald guy, big, DC, and like super easy. So I'm saying one of the factors that you have inherent, that I know you're a medical doctor, I know you're a pain management specialist, is that you have that going for you.
Mm-hmm.
You have that perceived, I'm already perceived as very credible.
Mm-hmm.
I already know coming in, I got to shine with what I'm doing because there's a prejudice of credibility for me in my profession.
Mm-hmm. Mm-hmm.
So yeah, it's not hard.
Perfect. Well, we'll keep in touch.
I've used that. You bet, Vic.
Thank you.
Yeah. Okay. Any other questions? You guys have all been great. Any other questions? Okay, so I'm going to let you go for tonight. I appreciate your time, your attention. Look for us. We'll do regular programs. I like this format, even though I don't like staring at the black wall. A lot of you don't have your cameras on and stuff. Come on these Zoom calls and bring your questions on any of the topics that I talk about, because I love the questions of the challenge. It just, everybody learns from that. So have a good night. Have a good rest of the week, and we'll see you on the next Zoom call. Thank you.